There's been a big buzz recently about Incident 2 billing, specifically that they may eliminate the ability to bill under these Incident 2 provisions for Medicare. In a June 2019 report to Congress, the Medicare Payment Advisory Commission strongly urged the elimination of these Incident 2 provisions because they are very complex and commonly abused. Let's talk a little bit about what is Incident 2 billing. So let's start with physician billing. When we bill under a physician to Medicare, we get paid at 100% of the fee schedule. So if Medicare would normally reimburse us $100, we still get $100. If we bill under an advanced practitioner, like a certified registered nurse practitioner, a physician assistant, a certified nurse midwife, we only get 85% of the fee schedule. So if Medicare would normally pay us $100, they will only pay us 85% if it is billed under a physician assistant. I'll use the example physician assistant. Now, it is possible to have a physician assistant perform that service, but bill under the physician and still receive 100% of the fee if we meet the Incident 2 criteria. There's a lot of very specific criteria that's involved in Incident 2. The first requirement is that the physician and the advanced practitioner have to be employed by the same group entity. I like to use the term advanced practitioner versus NPP because I've had some advanced practitioners like PAs or NPs that get a little bit offended by being called a non-physician practitioner. So when I say advanced practitioner, please understand that I'm referring to PAs, CRNPs, nurse midwives, etc. So that advanced practitioner could also be like a contracted or leased employee of that group. The second thing to consider is that this only applies to Medicare and Medicare patients, and there are certain services where Incident 2 criteria doesn't apply because they have their own service category. So like flu shots, Medicare says that those don't have to be administered by or under the supervision of a physician. So that's why you can kind of go to Walgreens or a CVS and just get your flu shot. A third thing to consider is that Incident 2 doesn't apply to hospitals and skilled nursing facilities. A lot of people consider this to only apply to place of service 11. That's not always necessarily true. CMS actually says, for purposes of this section, a non-institutional setting means all settings other than a hospital or skilled nursing facility. So check with your Medicare fiscal intermediary. Mine, Novitas, does say this can only apply to place of service 11, but then there's others like WPS Medicare, where it says most common is place of service 11. A fourth crucial thing about Incident 2 billing, and this is the one people remember a lot, but it gets confusing, is it has to be an established patient with an established care plan. So for example, if a patient goes in to see the physician and that physician says, hey, you have diabetes, I'm going to put you on metformin, here's some dietary changes you're going to need to make, and in 3 months, I want you to follow up with Jen. Jen is my physician assistant and she is phenomenal. So in 3 months, that patient comes in and sees Jen, the physician assistant. We can still bill under Jen if she is still following that care plan for that patient's diabetes. Now, in some instances, they can maybe tweak the medication a little bit, but as long as they are following that same care plan, we can still bill under whatever physician is providing direct supervision in that office today, not necessarily for the physician that provided the initial visit, but whatever physician we can bill under for that day that is in the office, we can bill under that physician for Jen services and get 100% of the fee schedule. If that patient follows up with Jen, though, in 3 months for their diabetic visit and says, oh my God, Jen, I've got itchy, watery eyes, my nose is running, my throat's sore, my chest feels heavy, I really don't feel good, that's a new problem, and Incident 2 goes out the window. And you have to make sure that that gets billed under the physician assistant and that we only receive 85% of the fee. Because if we bill that under the physician and take 100%, now we've overbilled Medicare for services that were incorrectly billed Incident 2. Now, the fifth thing that I alluded to is it has to be direct supervision. Direct supervision doesn't necessarily mean the physician is in that exam room with them. It means they're in that office suite somewhere. Not across the street getting lunch, not on vacation in the Barbados. They are somewhere in that office suite readily available. Now, direct supervision, you have to remember, this is Medicare, so some other insurances require different, and we'll talk about that in a bit. Some people get confused and think that they always have to bill under who established that care plan. That's not true. You have to bill under who is in the office that day providing that direct supervision. The sixth key is that there has to be active physician supervision. And this is where it gets a little complicated because Medicare doesn't define for us what that means. Some people will say, oh, we'll go by your state requirements, whatever they regulate, physician assistants, registered nurse practitioners. Some institutions will even form their own regulations. They'll say, here for our healthcare organization, we'll say at least once a year that physician has to see the patient in order for it to be considered active participation. I would assume that a Medicare reviewer would not want to see that the patient has been following up with Jen, the physician assistant, for the past 5 years and hasn't seen a physician, since that initial care plan. They want to see some sort of involvement. And really the key to that is documenting how that active participation is. The seventh key is it has to be something that's normally performed in the office. So you can't do a rhinoplasty in the office and then bill it under the physician when it's done by a physician assistant, because that's not normally something we do in the office. Now, where it gets a little tricky is, remember how I said this is a Medicare guideline? Well, different insurances have different guidelines when it comes to billing for advanced practitioners. A lot of the Medicare Advantage plans will say, oh yeah, we follow Incident 2 guidelines. So established patient, established problem, has to be direct supervision. Others will say, well, we follow a similar program, but we say that they don't have to be direct supervision. It could be general supervision. So in the case of general supervision, they can be accessible by any kind of electronic means, a cell phone, text message, electronic means. Then you have other insurances that say, yeah, always bill it under the physician, or insurances that say, oh yeah, always bill it under the advanced practitioner, or we can bill for physician assistants, but not for certified registered nurse practitioners. And we're going to reduce the fees for this ones, but not for these ones, and then general and direct. And so it gets really confusing when you think about all the different insurance requirements. So you have to really make a really easily interpretable grid that follows all the different contract regulations that you have for those insurances as far as supervision requirements, established patient, established care plan, all of that. And I think that's where people get into hot water, because we get so confused, and especially when patients are not even sure what plans they have. They think they have Medicare, but really they have, Medicare Blue Journey, some kind of Advantage plan, which has a different requirement. Some institutions have just said, well, it's not worth that extra 15% for what we would have to do to figure out who's billing for what and the penalties that could potentially be involved. Just always bill under the advanced practitioners for Medicare and we'll take the pay cut. It's really important to have a grid that determines when we are following true Medicare Incident 2 guidelines versus when we're following those Incident 2-ish guidelines versus when we bill under PAs, CRNPs, etc. The worst thing you could possibly do is incorrectly bill to Medicare, because while you think, oh, maybe I'm getting that extra 15% fee because I don't want to lose that, what you're going to pay in penalties if Medicare finds out that you are overbilling them is going to be astronomical. Maybe if you have an EMR that's programmed to help you out and you have some good registration staff to support that as well, that 15% might be cake. For other institutions where maybe they don't have as good of an EMR or staff that knows how to correct those billing errors, that 15% could wind up being huge in penalties. We're using advanced practitioners in the past few years like we have never before. They are an integral part now of healthcare organizations. So Medicare's paying a lot more money for services that are rendered by them, and they might just be looking to, hey, cut a few bucks, that extra 15%, and eliminate a lot of reviews that they have to do and auditing that they have to do in relationship to Incident 2 billing. At the end of the day, it might just be more beneficial for us to have to eliminate those Incident 2 services to eliminate all of that recoupments that happen and all the audit activity. So will Incident 2 services get eliminated? Could be. We've got a lot of crazy proposals going on right now with Incident 2, with ICD-11, with evaluation and management. Right now we're really kind of holding our breaths and waiting and seeing what's going to happen. So what do you guys think? Should we eliminate Incident 2 billing? Comment below and let me know.